Mute.
Hi, everyone. Thanks for being so patient with us. We will get started in just a few seconds. All right, so thanks for joining today on our Enhancing Payer-Provider Collaboration Strategies for Improved HCC Data Quality webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items. First off, this is being fully recorded. We'll send it to you after the webinar is done. Look for it probably in your inbox tomorrow. And then all attendees are in listen-only mode, but if you have any questions during the session, just put them into your Q&A chat, and we will get to them at the end during our Q&A session. Today, we have two of our IMO staff members. Sheena Koch, she's our Senior Product Manager at IMO, and then David Arco, he's our Director of Product Management. Sheena, if you don't mind going to the agenda slide, I'll walk through the rest of the agenda, and then I'll pass it on over to David. All right, so we're going to do a brief intro, talk about the challenges and what's going on in the industry, and then about our solutions and how terminology and technology can improve HCC capture and identification, and then how the collaboration can be more efficient between payers and providers. And then we'll go into your HCC strategy at your organization. All right, David, I'm sending it to you.
All right. Thanks, Jordan. All right. Well, on behalf of the team here at IMO, we thank you all for taking the time to join us this afternoon, especially those of you who don't know us yet. This is a little bit of a different audience than the providers we know and love, but we hope in the next 45 minutes or so to show you what they already know, that IMO is the best kept secret in healthcare. At our heart, IMO is one slide up, Sheehan. At our heart, IMO is a data enablement company founded on our clinical interface terminologies that allow providers to say what they want to say without the restrictions of standard coding systems, while ensuring that they have maps to the necessary codes and code systems for any use case, from billing and reporting to interoperability and research. We were founded 30 years ago now, and in that time, we've become the language of healthcare, particularly when it comes to documenting problems and diagnoses. Next slide. And we're proud to count nearly every major health system as clients and every major EHR as partners, as well as a growing number of other partnerships across health tech. We support various integrations, whether it's supplying dictionaries of our content, cloud-based or on-prem APIs, or embeddable workflow applications. And in many cases, we're foundational to the proper functioning of the EHR. For instance, we're proud to claim all but 2 Epic health systems as clients, nearly 90% of Oracle Cerner clients, every Meditech client, etc. I could brag on this slide all day, but the takeaway is really just IMO is already a trusted partner of nearly every major health system, and we're the terminology and coding used by 90% of US physicians every day. So what do? IMO is a data enablement company, but what does that mean? Well, we support the highest quality structured documentation at the point of care, that terminology I was talking about earlier. We offer workflow tools for managing that structured data once it lands in the patient's record, procedure coding and pref card standardization for surgery scheduling, as well as solutions for back-end aggregate data standardization, natural language processing, and value set management. Our clinical interface terminology is the foundation, though. It offers more breadth, allowing providers to document concepts not supported by standard code systems, while also offering greater granularity, allowing nuanced documentation of a disease state that is otherwise not possible in most coding standards. To give an example of how this works, here's an IMO concept for STEMI, for which IMO has created numerous terms that are lexical variants with identical clinical meaning, all allowing the provider flexibility in how she searches and represents the condition in the patient's chart, including acronyms, abbreviations, synonyms, and common clinical vernacular. Each term has its own unique IMO ID and is mapped to all administrative code sets required for any use case associated with that data domain. We perform numerous updates each year, and regulatory coding changes can be applied retroactively if appropriate based on the unique IMO ID. To give another example that maybe we wish we'd never heard from again, COVID-19. Being a novel disease, when COVID first emerged, there was no code for it. But obviously, there was a need to be able to document patients with COVID and in a structured manner that would support reporting and surveillance. IMO was able to create a concept for COVID, even though SNOMED and ICD didn't have one, with lexical variant terms, each with its own unique identifier, all mapped to the latest coding guidance. We also created concepts for COVID complications like pneumonia due to COVID, well in advance of the coding standards, in a unique structured manner that supported the necessary coding and surveillance, while updating our code mappings as the coding guidance evolved. Another key feature of our terminology is that it allows providers to represent complex conditions that require multiple codes to fully represent. For example, IMO's terminology allows a provider to document carcinoma of breast cancer metastatic to pelvis with a single search and a single term, while ensuring the capture of 3 SNOMED codes and 2 ICD-10 codes necessary, including the ICD-10 code C79.89, which I probably don't need to tell the folks on this call, is about 10x the RAF of the primary breast cancer. Now, with respect to RAF, one of the most important factors in accurately representing disease burden is accurate and specific coding. While some organizations may rely on coders and CDI specialists for this, those resources are often overburdened, and relying on them creates inefficiencies that we believe can be avoided by offering better search and capture tools at the point of care. Our breadth of clinically friendly terms makes it easy for providers to find the term that they're looking for. And our proprietary ICD-10 modifiers offer a streamlined workflow to encourage capture of the most specific ICD-10 code by presenting targeted questions to the provider. So accurate and fully specified coding can be captured at the point of care. In this example, with a single click, CKD was further refined to stage 5, which is an HCC, and on dialysis, which has an even higher RAF score. But as IMO evolved our portfolio, we recognized that our provider clients were certainly benefiting from being able to say what they needed to say about the patient, but we routinely heard that they could not see what they needed to see about the patient, and that those highly specific, clinically rich terms that providers were documenting were essentially getting lost in future encounters because the patient problem list, that clinical snapshot of ongoing chronic conditions that should really act as the starting point for each encounter, was for all intents and purposes unusable in the EHR. In most EHRs, these are just laundry lists of medical conditions with little organization or context and cluttered with out-of-date or redundant entries. So we created a suite of problem list tooling that can organize, contextualize, and curate the data on the active problem list. It includes a rules engine to identify and remove common types of problem list clutter that can also help reconcile outside data or suspects, and offer clear identification of those problems that may be relevant to a risk model with color coding to indicate those that are unaddressed in the calendar year. We really think that the problem list is the right tool to drive HCC management, as it is the clinical tool intended to manage chronic conditions longitudinally. HCCs are, by and large, chronic conditions that need to be managed over time. So based on the patient's payer and plan type, we have an HCC list that can pull together all confirmed HCCs, run them through the model's exclusion criteria, and present, based on the last address date, flags for the unaddressed HCCs with our action color of orange. These carry forward into the problem list so that the provider can be aware of these as they prepare for the encounter and act accordingly. And the latest addition to our problem list suite, Problem Discovery, can search the patient's record for HCCs or other chronic conditions that are not documented on the problem list, whether they were diagnosed in a previous encounter or mentioned in a clinical note, and we can present those to the provider in the problem list workflow for consideration. But we also recognize that despite the promise of interoperability, many providers are really living in a silo in their EHR, and they don't have the same level of visibility or awareness to a patient's HCCs that, say, a payer might. So we're excited about this problem discovery, not just for its ability to surface insights from within the EHR data, but also as a platform for delivering payer-sponsored suspect conditions or even care gaps to the provider at the point of care when they're primed to make those decisions. So now that you have a little better idea of who we are and what we do, I'm going to turn it over to my colleague Sheena to go into a little more detail about how we think about HCCs.
Thanks so much, David. Let's go ahead and pause here to talk a little bit about the impact of HCCs. And specifically, let's take a moment to pause and talk about the impact of HCCs specifically on risk adjustment. So a key focus in recent years, as more and more providers shift from fee-for-service to value-based care, what you'll see here are these five characteristics or attributes that contribute to risk adjustment. But let's focus specifically on HCCs for both optimizing clinical care documentation and chronic care management, but also those downstream impacts to payers. Now, hierarchical conditional code categories aren't a new concept, but as more and more organizations shift towards value-based care, there has indeed been renewed interest in the model. And it makes sense. Without solid foundational knowledge of HCCs, health systems risk lower rates of reimbursement, reduced care continuity and quality of care, and increased burden of the management of longitudinal health outcomes. Hierarchical conditional codes is one of the many risk adjustment methodologies that significantly contributes to the manner in which payers stratify risk, reimburse providers, and provide care to what is approaching nearly 55% of America, and that number is steadily compounding. Here's what we know about HCCs and its impact. Data shows that using just CMS HCCs capture at least 90% of the risk adjustment for inpatient and outpatient programs. When we think about applying Occam's razor to the challenges that we face with risk stratification and care quality, HCC capture and recapture for management of chronic conditions and comorbidities is a well-grounded strategic lever. So we know that HCC documentation is critical for base rate determinations as well as medical premiums. None of this is lost on our audience here, but a greater degree of specificity by way of categorically identifying and documenting those HCCs translate to improved RAF and increased reimbursement. IMO powers EHRs with proprietary mappings from various code sets, as well as specified coding from ICD-10 to categoric HCCs. Here at IMO, we've seen an effective payer strategy fosters correct coding under risk adjustment models, which are necessary to properly identify risk and enhance collective savings. So where do we start? Successful organizations ensure that providers have the tools to manage HCCs effectively. The first step is making providers more aware. And so engagement at the point of care, supported by clinical evidence and defined by payer risk stratification programs and initiatives, allow for actionable, up-to-date, real-time, patient-level clinical insights. It's critical that providers are able to quickly identify HCCs in preparation for or during an encounter, as well as when documenting new problems and diagnoses. To create a true feedback loop between payer and providers, we leverage technology to break down barriers such as cognitive burden, documentation redundancy, and gaps in care. Quality documentation, terminology, and coding, and optimized specificity are core foundations. But HCCs build on that foundation and provide the required safeguards to ensure care gaps are mitigated and reimbursements are optimized and that cost is reduced. These are priorities for both payers and providers. And there's quite a bit of evidence to back this up. Here's a study conducted by a Cerner site that implemented IMO Core and experienced a 6.9% increase in RAF post-implementation, attributed to a marked improvement in diagnosis specificity, upwards of 33%. And we'll dive more into the impacts of optimized coding and specificity in a bit, but for now, I'll hand things back over to David to talk a little bit about some of the challenges common to both payers and providers.
So we know we're onto something with that case study, and our clients do too. With rapid growth of our workflow solutions, IMO Core, in our major EHR partners, but we still see challenges to solve. I've already discussed at length how we're beginning to solve some of the point of care challenges. But despite the promise of interoperability, we still see that in practice, providers are still living in silos to a large extent. Reconciliation workflows are clunky and time-consuming, and data exchange via CCDA often results in loss of IMO secondary codes. So as that data moves through the ecosystem, a game of telephone occurs, and the patient's story becomes less clear, especially to the machines that rely on accurate and complete coding to be able to get their outcomes. Go to the next slide. This data degradation can have numerous impacts, numerous use cases that I'm sure you all are seeing today. Whether it's risk adjustment or quality reporting or population health management, Quality data is crucial to your desired outcomes. Without better quality data and better visibility and access to that data across the healthcare ecosystem, payers can better measure and improve the quality of the healthcare services of its members to ensure member satisfaction. We also see data problems at the point of care, which we're working to solve by giving providers tools at the point of care to better visualize, contextualize, and curate their patient records. We're committed to this because we see the problem is huge. Problem lists, regardless of EHR, are overwhelmingly dirty, and a good number of them are incomplete, leaving a gap in the provider's understanding of the patient's clinical story and their visibility to those important chronic conditions, many of which have financial implications. And this is where you come in. Payers have a bird's eye view of their members and have patient insights of which the provider might not be aware. So how can we close that gap, break down those silos, and create better communication between payer and provider to make sure the healthcare needs of your members are being met?
So let's talk a little bit about the payer-provider gap. So when it comes to data, we all know our industry has long been overburdened by data silos, factors such as risk or lack of true interoperability and data standardization, as well as modes of transmission and gaps attributed to factors such as claims lag time, all play a role in widening that chasm that exists between payers and providers. Data transparency really is key. So how do providers, or payers rather, communicate with providers? And when? Often communication between payers and providers is reactive and is initiated due to lack of sufficient data quality. In thriving ecosystems, providers require up-to-date, reliable data, and payers require clinical relevance, code accuracy, specificity, and context. Payer and provider partnership are vital to bring valuable benefits to MA patients, all patients. So where do we start? IMO really is the foundation of clinical documentation in nearly 98% of EHRs. What we've seen is that most gaps between payers and providers originate at the point of care. So whether those causes are cumbersome clinical workflows, hidden clinical notes, or poor utilization of the problem list, as David alluded to, these implications are far-reaching and are felt by providers and health systems, as well as payers. But what if? What if there was a way to optimize data pathways between payers and providers through proactive integrated workflows? Terminology and technology are effective levers that successful organizations leverage to improve code quality, care continuity, and optimize data transmission between payers and providers. Code quality really sits at the core of this solution by standardizing data and making it readily available, bidirectional, and reportable. At IMO, we're proud to support healthcare providers and payers in their mission to deliver high-quality care by providing industry-leading terminology and data integration pathways. We're dedicated to ensuring that our customers have the most up-to-date terminology to support rich clinical documentation, seamless workflows, and rich data normalization. How do we do it? Well, IMO's team of clinical experts and technologists have years of experience in a variety of fields like patient care and informatics, and these skilled individuals carefully curate our industry-leading clinical terminology by thoroughly monitoring all regulatory code systems like ICD-10, SNOMED-CT, CPT, and the like, and staying abreast of regulatory code changes and updating IMO's mappings behind the scene to allow for our clients to confidently and credibly complete regulatory reporting requirements. We also closely follow the latest up-to-dates to clinical practice and research and continuously assess our clients' requests for new terms and monitor ongoing changes to quality assurance metrics. We package these updates together in user-friendly formats so our clients have the latest clinical terminology with minimal disruption to clinical, revenue cycle, and other EHR workflows. So going back to what studies show, and that Concord study that we talked about a few slides back, now Concord identified that prior to implementation, they recognized that they had a specificity problem. And post-go live, they saw significant and sustained increase, as you can see here on the left, in coding specificity for all HCCs, including 9,000 net new HCCs, which led to significant RAF improvement. The data here shows what that looks like for 4 specific categories. So you'll see CKD, depression, obesity, and type 2 diabetes represented here. But what you'll see overall is a consistent increase in the specificity time after time. And so we know that data quality is meaningful for both payers and providers. But once we've optimized the data, now what? In the ever-changing landscape of healthcare, successful collaboration between payers and providers is really crucial for ensuring optimal patient care and providing effective reimbursement strategies. So in the last year, IMO has successfully partnered with payers to serve as a data conduit between both entities. And we're well positioned in the EHR, industry experts in terminology and advanced clinical insights, and a trusted partner for both provider organizations and payers. Here's how we're improving the payer-provider gap. IMO's proprietary data pathways allow for the identification of patient-level care gaps that are defined by payers and proactively surfaced at the point of care. The tenets of our provider-payer workflows are founded in ensuring consistency across systems, so that accurate clinical data exchange, streamlined communication between payer and provider injected directly into the clinical workflow, payer access to complete, reliable patient data, that's that bidirectionality that we talked about. And of course, the foundation of this is being able to highlight and identify gaps in care at the patient level. One of the most important factors that we considered was our ability to support getting reportable insights back to payers and fostering that bidirectionality between payer and provider and creating a holistic health data value ecosystem. So our applications ensure that payers are prepared. Risk adjustment data validation, or RADV audits, as we all know and begrudgingly love, are the government's primary tool for identifying improper payments. It's a reality of the landscape and the world that we live in. Now, the purpose of those audits, as you all know, is to validate the accuracy of HCC diagnosis codes and determine whether health plans have obtained overpayments for reporting conditions that didn't have impact on medical care. So data validation rates have been reported to be upwards of 33% for CMS HCCs, with the OIG reporting that they've indicated even higher error rates. It's estimated that medical MA health insurers have overcharged Medicare by nearly $30 billion over the last 3 years. So a couple of examples, gross examples of what that looks like across the industry are MA payer diagnoses that don't match the documentation. So think about things like depression documented, but major depression, single episode, mild, as a more appropriate, more specified code, or diagnoses being addressed or irrelevant to the encounter. Additionally, diagnoses that are typically acute patient conditions that no longer need to be on the problem list or patient chart, and status of malignancies that are unclear within the record. So again, some of those redundancies in the coding. So our solutions reduce those redundancies via optimized problem list management, advanced code quality, payer-guided insights, and of course, HCC identification, capture and recapture for the pertinent calendar year and beyond. So let's take a look at a quick example rather of a high-level technical architecture of a payer-provider integration pathway. And so in this particular example, a health plan is able to provide us with their patient gap data. That data is then mapped to a patient and it's presented to the provider in workflow. This is all powered by supporting evidence that's made available for review by the health plan. And so again, most importantly is that these outbound gap reporting data is sent back to the payer and engagement metrics are logged so that they're able to ensure that the data that is gleaned is actionable, insightful, and up to date. And here's an example of what that looks like at the point of care. David alluded to this. The discovery functionality is leveraged by payers to optimize the way that they proactively communicate with providers. In the tab that you see on your right, you'll see categoric HCC suggestions for behavioral health and cardiac and vascular. Providers have the option to add or dismiss and expand to view related clinical relevance defined by the payer. So let's talk a little bit about some of the key takeaways. We want you all to feel empowered leaving here today knowing that we've identified a couple things. One, gaps in the payer-provider ecosystem contribute to a variety of challenges in our industry, all of which have the potential to impact the care continuum. But the good news is that terminology and technology have the potential to really optimize those relationships. HCC capture and the management of chronic conditions and comorbidities ensure risk stratification, reduce costs across our industry, and the burden of care across the healthcare landscape, all serving to improve health outcomes for our patients. Organizations that are committed to reducing those gaps in care rely on technology for consistent, reliable tools that help them optimize the data, provide proactive solutions, and simplify workflows beyond and at the point of care. So how can IMO help? We have the opportunity here to clear the path to accurate clinical patient data by way of a couple things. Fully integrated bidirectional communication with providers at the point of care, clinical terminology leveraged by providers in your payer platform, and standardized and enriched clinical data. So let's talk more about your payer strategy. We'll go ahead and hand it back over to Jordan for Q&A.
Thank you so much, David and Sheena. All right, so at this time, we'll do our Q&A session. So if you had any questions coming in or during the session, please type them in. So one of the questions that came in is, what EHR system does this work in?
Yeah, we currently have active integrations of this in Epic, Cerner, and NextGen. And we are having conversations with our other EHR partners about expanding the IMO footprint to bring discovery into those EHRs as well. And I should add, these solutions are also integrated directly into the provider's workflow. That's the biggest challenge. So when we are looking at integrating discovery into one of our EHR partners, the question is, how can we integrate this into the provider workflow? Ideally, our solutions are point of care solutions. We want to give the providers the tools to make these decisions at the point of care. So that is where we are trying to inject these. The app screenshot that we showed is the problem list for Cerner clients who use IMO Core and Discovery. That plugs in, replaces the native problem list, and this is what they use to prepare for their encounter, review the patient's chronic conditions, and the ICD-10 coding is all done through our application. Same story in NextGen. We are the problem list and are the diagnosis capture for our NextGen clients. Epic, a little bit different. Epic, our application is used for problem list curation. We provide the content to drive Epic's problem list tooling as well as their diagnosis capture. Epic doesn't have great tools for problem list curation, but our application is that. So for clients who, about half of Epic clients have licensed our IMO Core workflow solutions. So they have our problem list curation application that can launch within the encounter. You can actually configure Epic to automatically launch our application when necessary, or for appropriate scenarios, certain providers, certain patients, certain encounter types. You can have the app automatically launch. So it's really clear to the provider when it's to be used and when the organization wants providers to be able to review these check for these undocumented problems.
Great. All right. Does this work? Excuse me, I'm so sorry. Does this work for quality as well as risk adjustment?
Yes, it can. You can really think of our integrations, think of Discovery as a blank slate for you. We can support whatever sort of integration or interaction you want with providers, as long as the provider organization is open to that engagement. So certainly our initial focus is to close those HCC gaps, give providers the visibility that they need. But we're also working in the direction of closing care gaps as well. But if there's any other, what we're really trying to achieve here with this is better communication between payer and provider. Can we help you engage the provider at the point of care, give them the information that they need to make informed care decisions?
Great. And you just mentioned care gaps. So is the identification of patient-level care gaps with IMO automated?
IMO is not actually identifying the care gaps, but payers often are aware of these. And we are able to facilitate that communication.
Great. All right. How is Discovery integrated into EHR workflows?
Yeah, I think I just hit that with an earlier question. It is implemented, it is integrated at the point of care where possible. IMO becomes the problem list that providers use in their clinical workflow. If the native problem list is already pretty good or supported by our content, then we can facilitate just a curation application that can be launched in certain scenarios. We also have the ability to create these same solutions as a backend tool for organizations who are relying on coders and CDI folks to do some of this work. For EHRs where we are not able to, where there's no path to integrate this solution at the point of care, backend CDI or coder tools are certainly a path to that integration.
Awesome. So it looks like all those questions came in. So we're going to go ahead and close out. I hope you found everything useful. Thank you, Sheena and David, again. If you have any questions, you can contact our sales team at sales@imohealth.com or just visit our website at imohealth.com. Thank you so much for attending, and I hope you have a great rest of your day.
Thanks, Jordan. Thank you all.